you here today. Thank you very much for waiting for you. You didn't wait for that.
All right. Well, welcome everyone. Yeah, today much more crowd than yesterday, so God be with me. All right. So, today I wanted to talk about cell-free DNA. I mean, I'm gonna go into transplant, so that's like for me as an introduction to try to learn more about transplant. That's why I chose the topic. And before I start, I'm just gonna say there are some Arabian sweets from Jordan. So whenever you're out, just try some. Okay. All right. That's not bored. It's like you can ask whatever questions you want. If I don't know, I'm gonna relate to the transplant. All right. You're gonna hear me talking about different companies, Alloshore or Prospera. Nobody paid me, so I just want to make sure no disclosures. Okay. We're gonna discuss the biology of cell-free DNA. We're gonna go over the evolution of methods measuring cell-free DNA. Touch base a little bit about the different clinical applications of cell-free DNA, the role of donor-derived cell-free DNA as a biomarker in diagnosis of rejection, and then other roles that are in the literature regarding use of cell-free DNA in transplant medicine. Just as an introduction to my topic, I want to say that basically, transplant medicine is all about this fine balance, finding the correct immunosuppression level to try to prevent rejection, and at the same time, avoid with excessive use of immunosuppression, the side effects, including infection as well as malignancy and many others. Looking at this study where they almost, analyzed 40,000 kidney transplant from 1996 to 2018, you can see that over time, the rate of graft loss has actually decreased both in deceased donor as well as living donor. However, for example, if we take the 5 to 10 years, you can still see that, back in 1996, it was 7%. So 7 out of every 100 kidney transplant they will lose their kidney in 5 up to 10 years. And then even, back in 2010, the most recent is like they are still within a relatively significant number, around, above 6%. And this is a little bit less, but overall, the numbers are still significant. We're talking about anywhere between 6 to 10% loss rate of graft loss with time. And when they looked at what is the cause or the most common cause of graft loss, actually acute rejection accounted for most of the early graft failure. So for example, in this study, they actually defined early by 6 years, up to 6 years, and they found that 40% of the graft loss is related to acute rejection. And the 40% is divided ABMR of 32% and TCMR, T-cell mediated rejection accounts for 8%. And when we look at, diagnosing rejection, the gold standard remains to be kidney biopsy. And we all know the problems with kidney biopsy being invasive, expensive, with its own risks, and how frequent can we do it? And it's like a puzzle that we try to diagnose rejection. The current tools we have is serum creatinine, and we all know the problems with serum creatinine, how it lags behind, it's a late finding. And just like it is the proteinuria, which is also a late finding. And then other pieces of the puzzle, including transplant, ultrasound, drug level monitoring, biomarkers that have been there for a while, like the DSA. And from my understanding, it has been in practice since early 2000s. But they have been trying over the last decade to try to find some non-invasive markers that would, try to help solve the puzzle and try to avoid kidney biopsy. So many are under study, many emerging non-invasive biomarkers. You can see, for example, like blood mRNAs are under investigation, some example, granzyme, perforins, and urinary mRNAs like CXCL10 or perforin. And you can see that there is, modest sensitivity and specificity for all. But if you look at the literature, most of them are actually focusing on donor-derived cell-free DNA. And that's, one of the reasons I wanted to touch base about. So let's talk about biology of cell-free DNA and start from biology 101, just to, I like simple pictures. So that's, I try to make it as simple as possible. The DNA molecule, we all know that it's base pairs and it coils around each other and then it gets combined with histones. The DNA histone complex is coiled and the coils will form loops and the loops will eventually pack together and form the chromosome. What is cell-free DNA? They define it as non-encapsulated DNA fragments that is shed into the bloodstream. It is actually released from any cell that is undergoing apoptosis or necrosis. When they looked at the sizes, it's typically around 150 to 200 base pairs in length. And it was actually first identified in 1948 by two scientists, Mandel and Mathias, in human plasma. When they looked at how it gets released into the circulation, there are three main ways. Apoptosis of cells is one, which is the programmed cell death, necrosis of any cell, as well as netosis, and NET stand for neutrophil extracellular trap. And that's a way of the neutrophil, activated neutrophil, how they defend against microorganisms, where they release this cell-free DNA with histones as well as with antimicrobial proteins. And there is minority that gets actively secreted from cells that are not apoptotic. And this led, people, and it's not only coming from our own body cells, it comes from fetal placental cells that gets shed, from transplant, which is our topic today, transplant organs, from infections and microorganisms that have DNA or mRNA also get shed, and from cancer and tumor cells as well. As we said, in this study, they looked at the sizes, and you can see that whenever the cell gets apoptotic or necrotic, there are nucleases that will divide the DNA, and this gets shed into the bloodstream. And when they measure, there is a wide range of variety of the sizes, but you can see that most of the sizes are around 150 to 200 base pairs that are in the bloodstream. And they found that it's limited concentration. It's only 50 nanograms per ml on average. And when they try to study how it gets cleared, there are three main ways. The majority is through the reticuloendothelial system, including the spleen as well as the liver, some transrenal filtration with the GFR, as well as the nucleus that gets them digested. And they have found that it actually stays in the body and the blood for a short period of time, around 30 minutes to 2 hours in circulation. And that's what made them think that it's a good real-time marker of cellular injury that they can use to diagnose rejection. Clinical applications, I'm just going to touch briefly on things that are not transplant related, but they call it in the literature the liquid biopsy. And this is because they have used it in multiple different applications. Cancer management, they have been using it to define different types of cancer, whether in screening or monitoring response to therapy. Non-invasive prenatal testing, especially in fetal sexing or genital abnormalities. Organ transplant, which is our topic. And nowadays, we see ID ordering all the fancy tests, the Carious test. And it actually has the same mechanism. They look for cell-free DNA that gets released from microorganisms. And some others that are including chronic illnesses, acute illnesses, and it's under investigation in multiple aspects. Putting it in simple, you have transplanted kidney, the donor now will have, the recipient now will have donor DNA that gets, whenever there is injury to the allograft, this DNA will get released and it will be detected in the bloodstream of the recipient. So beginning of the story in the transplant, as I told you, this goes back to 1948 when it was discovered by Mandel and Mathias, but it wasn't until 1998 when Lowe and colleagues actually reported the discovery of transplant organ-derived DNA in circulating in the bloodstream of 36 kidney and liver transplant recipients. And at that time, they commented on it as, alluded to the possibility that this donor-derived cell-free DNA could be used as a non-invasive marker of solid organ transplant rejection. I just wanted to share this when I was trying to make the grand rounds. This is like PubMed search when I looked at the keywords donor-derived cell-free DNA and transplant. And you can see the first studies that are in those kidney and liver transplant was in 1997. And you can see things stayed calm. And then in the last 10 years, things have really exponentially grown with so much literature that is being published on it. I'm happy that, kidney transplant has been one of the pioneers in this field. Actually, the first, and we're going to touch base on this study, Bloom et al., and it was published in JASN 2017. And then, other transplant teams got jealous and they started, using cell-free DNA. So the heart in 2019, liver in 2021, but there are other studies, but those are one of the, some of the key studies that have been published. Advancing in measuring techniques and assays. So, just going back a little bit to biology. This
Protein. Yeah.
yes.
Yeah.
So, if we compare each other's DNA, we actually have less than 1% difference between each other. But this small difference is sufficient to distinguish donor from recipient DNA. And what they have looked at is genetic markers, which they found that they are highly heterogeneous within the population. And those genetic variations serve as unique identifiers that make them easy to identify recipient from donor. One of the most common is the SNP, which stands for single nucleotide polymorphism. And simply speaking, it's like variation in one base pair that is likely to be different between different people. Others include, insertion deletion and copy number variations, but there are many that are not, the scope within the scope of this talk. So how do they detect it? They first take a sample from the recipient that they are suspecting rejection. They do separate the blood and the plasma, and then they try to screen for this cell-free DNA. And they look at those different SNPs, or for example, if there is a sex mismatch donor and recipient, they look at some unique genes in the Y chromosome or insertion deletion detection. And then they quantify each that is related to each, whether it's the donor or the recipient, by different methods. And those have, evolved over the years. Some examples is quantitative PCR, digital PCR, targeted next generation sequencing. And after all, they would look at monitoring the DNA as a ratio. And we're going to touch base about the difference between the ratio and the absolute value. But they look at how much percentage of the donor-derived compared to total cell-free DNA, and that gives us an idea of the status of acute rejection. How did, there are three phases that this has developed. The first, which I already, mentioned, is the 1998, and this is the 36, the same. What they used at that time is there were female recipients that received kidneys from male donors. And those female recipients actually showed Y chromosome DNA genes, and that made them, identify which is which. But the major limitation, as you can imagine, is that this is only applicable to gender mismatched when there is a male donor and a female. So with time, they tried to, develop the process, and they were able to extract DNA from both donor and recipient, sequence both samples, and then identify the differentiating SNPs or other genetic markers, and they track the amount of those in the blood. But the limitation as well is, you can imagine, 90% is, or maybe less a little bit, is donor-derived, disease donor. So it's really logistically challenging to get DNA from disease donation that can happen from, nationwide or even internationally. And that's a time-consuming as well as expensive. So the third phase that they were able to reach is what we use nowadays, is using the SNP panel approach. And what made this possible is that they were able to collect and use the data from large population genetic studies. And they are measuring now panels of SNP that are homozygous in recipient, but differ from the donor. And this can be accomplished without donor genotyping. So that's the biggest, positive about it. And the other thing is it's universal. You can apply it to anybody. The only one exception is when you have an identical one. So the assays that are sponsoring this talk, AlloSure, Prospera, Track, and VitaGraft. And, AlloSure is related to the company CareDx, and they use a technology called targeted NGS. They actually have initially started looking at 266 SNPs, but then they increased it to 405. However, Prospera, they are related company Natera, and they use a different technology called multiplexed PCR, and they look at almost 13,400 SNPs. Those are the two most common in the United States. There is another one, Track, transplant rejection allograft, Check, and VitaGraft that also, use different techniques, including next generation sequencing and digital droplet PCR.
Would you entertain a question?
Yes.
So the trap, that is two components, right? The actual cell-free DNA is the true graft component. That component, that's
Yes,
right?
yes.
Right.
I think the major name, Track is the major.
No,
Yeah.
that's composed of two separate
Composed of,
components. The
yes.
actual cell-free DNA is
True graft. All right. Well, so because AlloSure and Prospera are the most common, I'm gonna touch base a little bit about them. So AlloSure actually was the first commercially available donor-derived cell-free DNA, and it was developed specifically for transplant purposes. It was FDA approved, and they look at 405 SNPs across all 22 chromosomes, except the XY chromosomes. And they use the target next generation sequencing. However, Prospera, initially when they developed Prospera, it was mainly for prenatal testing technology, and then they adapted it to use it in transplant medicine. And as you can see, it's not all over the place, all over the 22 chromosomes, but more on specific chromosomes, 2, 13, 18, and 21. And you can imagine, because this was developed for prenatal, so they were their aim was to try to identify the most common trisomies. And they used a different, approach, which is the PCR approach. But both of them do not require any prior genotyping of either the donor or the recipient. In this study, actually, when they looked at how the kinetics of the donor-derived cell-free DNA changes soon after transplant, they actually looked that there is an initial elevation, which they related it to the post-transplant surgical trauma that happens. However, there is a rapid decline, as you can see, and then levels fall quickly in the first week. And actually, they have found that it reaches almost a baseline of approximately 0.46%, and this is by day 10. This study was done on 42 stable graft kidney transplant patients, and then other studies that I'm not mentioning here, but those were done in heart and liver, and they found a similar kinetic graph. And then in the monitoring phase is like it has stabilized and remained stable, and this is what enabled us to think about it as a non-invasive biomarker. If it gets up, then there is something going on with the possible rejection. So going into the applications of donor-derived cell-free DNA in the transplant medicine, I'll start by talking about the diagnosis of rejection, and then I'm going to touch base a little bit how we use it in prognostication, and then in immunosuppression. So as a diagnostic rejection biomarker, the first and the major study that was done was the DART study, and this was published in JASN back in 2017. And this was actually the first prospective multicenter trial that evaluated donor-derived cell-free DNA in active rejection. They looked at 102 kidney transplant recipients with 107 for-cause biopsies that were done. And they used AlloSure in this study. So what did they find? Let's look at the right side here to get it out of the way. First, I mean, this is, or this right side, this is the creatinine graph. I don't know where the mouse went, but this is the creatinine graph that they looked at. And you can see that, not surprisingly, the no active rejection group and the active rejection group didn't have really significant difference in the creatinine levels. Then they looked at the donor-derived cell-free DNA, and the median in the no rejection group was 0.3%. However, the median was in the active rejection group was more than 1%, actually 1.6, and this was statistically significant. And then when they looked at the area under the graph, they actually found that for the donor-derived DNA it's 0.74. However, for the creatinine that we all use, it's only 0.54.
So when you think about this, there's no reason to expect that the creatinine would be different.
Mhm.
But did they look at change in creatinine from from an individual's baseline? Because there's just a broad range of creatinines, of course, they're not going to be any different. But did they relate it back to 2 months ago and look at a acute change?
So this is the change from, serum creatinine change, or you mean like absolute numbers of creatinine versus like,
Absolute change in creatinine from a patient's own
I see,
baseline.
I see.
Yeah, this is just comparing
This is just,
creatinine to creatinine between the two groups, and of course, there's not
Yes.
going to be a difference.
yes. And I mean, and that's why, yeah, exactly. And that's why, I'm more, trying to relay the information that is related to the difference between the active and the active rejection and the non-reactive rejection, rather than compare it with creatinine.
Right, but because in some cases, creatinine is a hint that they have acute rejection.
Mhm.
So it's not like it has a sensitivity of 0. There
Yes.
is some sensitivity.
Yeah.
So I think it's important to compare it. When you're saying creatinine is worthless, you should use a good measurement of
Mhm.
creatinine before you say.
Now, I have another question on that extreme graph.
Yes.
So what do you think about the, if you do look at the range, not the interquartile range, but the range of highest to lowest and the distribution and overlap?
Yes. I
Did you
mean,
analyze those things?
yes, they actually did. And this is, gonna be in my, next slides, because they looked this as a group, as the whole group of the no active versus active rejection, and they didn't specify which type of rejection they looked at. And, and actually, the borderline rejection was actually included in the no active rejection. It wasn't included in the active
Yeah,
rejection.
but a priori, before you do the test, you don't also know the rejection, right?
Yes,
yeah,
yes,
right.
that's like after biopsy is proven to have like no active rejection.
So all of these patients who had no active rejection got biopsies too?
Yes,
Are these status is for biopsies?
yes, for cause biopsy, center protocol, like center.
That makes sense. So there were no selection bias.
No.
Everyone
I don't
would
think
biopsy at a certain time frame for the transplant.
And maybe for the purpose of, it's a trial, right?
Mhm.
So maybe it's in the procedure.
How far, are they from, they were from the time of transplant?
At different like timing, yes, but most of them I would say within 5 years. Like early, like in the literature they say early, and most of them are within 5 years. And this is like the other graphs that they looked at, and basically you can see that there is somehow a modest sensitivity and specificity, and the negative predictive value for DNA. And in this study, they actually used a cutoff of 1%. And it was like around 84% when they used like the 1%, as well as 60% positive predictive value. Now, as a screening test, I think, we all want to look at the sensitivity to try to be higher, and this is like 60%, so not that much.
Yeah, but again, just because this is a very important point,
Yes.
and that's our argument of using this as a protocolized Q1 month. Because the procedure is 61. This is a good thing for rule out.
Mhm.
But it's just like doing stress test on everybody in the street and having we have biopsy people and with negative biopsy report based on this.
Okay. Okay. And then, they tried to look, to answer the question, they tried to look at, different subtypes of rejection. They looked at chronic active ABMR and then acute active ABMR and TCMR. And they, noticed that the median for the ABMR is much higher when you just look at the ABMR people. And it got up to 2.9%. However, the median in the, donor-derived, like the TCMR, which was like the 1A, the mildest, is 0.2%. But in the, the higher grades of 1B, 2A, it was 1.2%. So not a whole lot higher.
So
So
what was the explanation?
the explanation actually is basically that theories say that basically that antibody-mediated rejection is more of an, the immune system, the antibodies will target the endothelial cell and you have the glomerulitis. And that's why, you have more chance to release cell-free DNA from the endothelial cell into the blood rather than T-cell mediated rejection, which is more of focal, interstitial, as well as tubular disease that is, less likely to release this cell-free DNA into us.
After a certain point that you don't have 2A, 2B, and 3, which involve arteritis.
Which involves
So that's-
arthritis.
You have to qualify that.
Yes, yes. And this is, when they looked at the ABMR as well, the median, after this study, actually, the median was significantly higher in the ABMR, and this was statistically significant. So soon after this study was done in October 2017, this was Medicare reimbursable in the United States to be used in the detection of rejection in kidney transplant recipients. Now, this is actually, just a table to summarize, the differences in the specificity sensitivities when they were looking at all rejection, as well as when they only looked at ABMR. And you can see, for example, like the area under curve increased to 0.87, the sensitivity increased up to 81%, specificity up, well, almost the same, 84.7, 83.1. The negative predictive value increased up to 96%. However, the positive predictive value is, even got lower. So the DART study was taking 1% as the cutoff. Now, they did another study done by Huang, which they took a lower cutoff and they wanted to see how this affect the sensitivities. And, the sensitivity actually using a lower cutoff increased, not surprisingly, up to 79.4. The specificity went down, and the sensitivity in the ABMR, actually in this study, they reported it as 100%. So they were able to detect, all of them. However, the specificity was like down to 71. And the third study that they did, which the first two studies, they looked at AlloSure. The third study that they did was Signal study, and they are the first that used Prospera, or one of the first that used Prospera. And they looked at 217 plasma samples, and they used a similar cutoff of 1%. And those 217, actually, 38 of them had active rejection, and their median donor-derived cell-free DNA was 2.3%. 72 had borderline, and the donor-derived was much lower at 0.6%. And the 82 were stable allograft was 0.4%, and some other injuries like ATN or AIN were like 0.7%. Now, I had this question when I was, reading about it. It's like why ATN doesn't, cause, but it's similar to what we were talking about, the TCMR, that ATN or so up to a certain degree, you're talking about tubules, focal interstitial inflammation, rather than, endothelial injury, glomerulitis, as well as arteritis. So they claimed in this study that what they have found, which is different than the AlloSure study and the DART study, is that the fraction of donor-derived cell-free DNA did not differ between ABMR and TCMR group. They actually found that even in the TCMR group, it was even high, 2.2% as well as 2.7%. And they claim that these results are novel, considering that this is different from the DART study, and which used a different assay. And this found significantly higher donor-derived cell-free DNA in ABMR, as well as TCMR.
Could they have had more T-cell mediated rejection of vascular
Yeah,
degree?
yeah.
Could be, yes. That's one explanation. And the other explanation, or like the other theory is, they claim they didn't specify why, but they said that it is possible that is because of the different methodologies that they look at. But yes, it could have more, aggressive T-cell
Yeah,
mediated
do you
rejection.
know the fraction of patients that had a higher grade TCMR?
Not
in
on
the
top
study?
of my head, no, but I can get them to you. So, those three studies, and then, things, and then, the question that has risen was, which is better, AlloSure or Prospero? I didn't find a lot of studies comparing them both, but this one study I found, which basically looked at 76 kidney transplant patients with 11 biopsy-proven rejections, and they didn't really find any difference. It wasn't statistically significant, the difference between Prospero having a larger donor-derived cell-free DNA, or any difference in sensitivity, specificity, NPV, or PPV. The only significant difference that they were able to document is the turnaround time. AlloSure was shorter time from blood draw to result.
Do you know the absolute days value in it?
I think around 3 days
Versus-
versus 7 days, or 5 to 6 days, I think.
Do you mind me, which one is NGS and which one is PCR? Is AlloSure on NGS?
Yes.
I
AlloSure.
thought NGS takes longer than PCR in general, or oncology standpoint. I don't know, maybe it's a different. Thanks.
I'm not so sure.
Because AlloSure gives you access to their database without waiting for to fax or send the result.
Maybe it's a
They give
technical.
a password, you can look at it directly.
So it's a technical. issue.
I think it's more of administrative, whatever, logistics, I think.
Yeah.
Administrative. PCR takes 2 hours and about half an hour to set up,
If you
depending
say
on
very
number of
quick, yeah.
samples. So it shouldn't,
I think this is their different.
Yes. And then, another question was risen was, is fraction better, or is it the absolute value that is better? And, the theory is, just like we do a spot protein to creatinine ratio in an unstable AKI, a similar, thinking, is the reasons why we want to report a fraction is because it's less sensitive to pre-analytical variables. It can be compared between different studies and techniques, and it's not affected by clearance rates because both the donor as well as the recipient will be cleared at the same. And some of the pre-analytical variables that they mentioned is whether the processing time, technique, and storage conditions. And the key assumption when we look at the donor-derived fraction is that the recipient cell-free DNA is constant all the time. So whatever change in the percentage, it's because it's related to the donor-derived cell-free DNA, but this is really not the case. We can have a lot of potential confounders, including any host cell damage, which will increase the denominator by increasing the recipient, but without really affecting the donor-derived cell-free DNA. And those are example of cases: exercise, infection, leukocytosis, and autoimmune inflammation. So they proposed the alternative of measuring the absolute value. And in this study, for example, they looked at 303 stable kidney recipients with 929 plasma samples, and they compared the absolute levels with the cell-free DNA. And what they have found is that the absolute value actually remained stable over the observation period in a stable patient, but the donor-derived cell-free DNA percentage, in fact, increased. And the theory they said is basically when you start someone on a transplant, you're going to give them a lot of immunosuppression. So you're going to cause a lot of, cell death, like white blood cell apoptosis. However, with time, you're going to reduce the immunosuppression, and that will lower the amount of recipient cell-free DNA that is released into the system. So the ratio will get bigger, but it's not because of the donor-derived cell-free DNA. So I think the debate continues until now, whether, the percentage is better, and they claim that the percentage can be easier comparison across the studies. The absolute value was potentially more accurate in certain scenarios, like when there is a recipient involvement. And the theory that the question they asked is combined reporting more, helpful than either alone? And this is the trifecta study that came, and they looked at, it's a multi-center international sample collection. They looked at more than 360 donor-derived cell-free DNA. And, they tried to predict the percentage using the percentage as well as the absolute value. And their, cutoff using the percentage was 1%, and the absolute value was 78 copies per ml. And this actually had yielded a positive sensitivity of 83% and 81 specificity in the test. And they concluded that combining both might be more helpful than just using one alone.
Then how do you do that? How did they do that?
How did they,
Yeah, I don't know how to do that basically.
like, how did
Combining
they?
them to interpret or to make a prediction?
I think, well, what they were trying to do basically is looking at the cutoff, if it is positive or negative. Like in the absolute value, if it is more than 78, then it is like resembling rejection. If it is less, then it's
So
not
you use
rejection.
one or the
So it's
other.
like, yes, it's like either or. It's
So
not like a
this-
continuous.
So this is Prospera.
Yes.
So that is the main differentiation. Emphasize, AlloSure is percentage only. Prospera reports
Is
both
absolute.
the absolute
As
as
well
well
as
as
the
percentage.
Yes. All right. And then, moving on to another, some studies that looked into the correlation with DSA. And, we all know that the DSA is, in the criteria of diagnosing rejection. So, in this study, actually, they have found that basically when you look at donor-derived cell-free DNA, and when you look at DSA alone, and if you compare when looking at both of them, to give you an idea, using a 1% cutoff, the positive predictive value for ABMR actually increases. It's almost, additional value. You go up to 81%. And you can see here that, for example, the ABMR people had a, donor-derived around 3%. If they didn't have rejection, but they did have DSA, and I'm going to touch base a little bit about like how some DSAs are, pathogenic, but some others might be benign. And the people who are DSA negative also had a low donor-derived. So the point I'm trying to relay is that, maybe the combined finding of positive donor-derived cell-free DNA as well as positive DSA significantly improved the diagnostic accuracy for antibody-mediated rejection, potentially reducing unnecessary biopsies. And this is a nice case example they gave, basically is, this is a patient from
I'm sorry, I have to correct that. It does not, the gold standard is still the biopsy. If one or the other is positive, it makes you biopsy them sooner.
Mhm.
So you decide
Yes,
earlier.
okay.
But you cannot say that because you use both of them, you can get
You can
away without the
exclude,
biopsy.
yes. And all the studies right now, and even, in the conclusion, it's not, we hope to replace the biopsy, but, kidney biopsy is gonna, remain the gold standard, yes. And just, this is an example where like one patient from the DART study actually, they actually had a positive DSA, and that's why they ended up doing a biopsy. But during this time, his donor-derived cell-free DNA was still, within normal levels. And they didn't find any rejection. And at the same time, he had another DSA positivity that they were worried about, and they biopsied him, but there was no rejection, and the donor-derived was still below 1%. And, the 3 biopsies didn't show any rejection. The 3 times there were DSA positivity, but the donor-derived remained negative. However, for example, in this case, and then the clinical implication they were trying to say is that donor-derived cell-free DNA can help you differentiate whether the DSA you're seeing is really pathological causing rejection, or is it, more of a benign DSA that's not causing active rejection.
Did they correlate with creatinine in it?
in this is the creatinine. The yellow is the creatinine, and
Oh, sorry.
you know,
Yeah.
this
it's
is the
clear. Okay,
creatinine.
sorry.
Yes. And this is, you know, another example where they did, you know, DSA was negative in 2 times, but there was like a concern about, you know, rising creatinine, but the donor-derived cell-free DNA was negative. However, when there was like both DSA positivity as well as the donor-derived cell-free DNA increased significantly, that, you know, when they did the biopsy, that did reveal active acute ABMR.
Quick question.
Yes,
Can you go back?
yes.
When you said pathological DSA, how did they define pathological DSA? Meaning, if you had histologically proven rejection and you had DSAs, were those DSAs pathological or
No, because I mean, in both, they didn't find any histological findings. They only find IFTA, basically. They didn't find histological findings of rejection. Otherwise, they would have called it, you know,
right? So what is the definition of pathological DSA then?
when there is histological evidence of.
Right.
That's, you know, what they were trying, because, you know, they defined it because they found DSA, but when they did the biopsy, they didn't find histological rejection. That's when they called it, or assume that it's
Not
non-pathological.
pathological
I mean,
DSA.
that's a retrospective definition.
Yes, it's a
Right.
retrospective. Yes, it's just the way. Yes, I mean, yeah,
Yes.
it's like the
Because-
people who did
Because pathological DSA is basically the data is that the DSA that fixes complement
Let's.
is pathological DSA, but there are certain studies where they actually identified pathological DSAs.
A more accurate, you know, description is DSA that is causing histological changes
Rejection.
and rejection.
Okay.
Yes.
So this
So
is,
this exclude DSA causing a molecular biopsy positive rejection.
Yes. That's
So this
like
is-
a long.
so this is
Even the
two
mouse
case
fell down.
reports with 4 DSAs. That doesn't prove anything. So I think that conclusion is a little
Yes.
too robust.
Because what is pathological DSA? So it has
That's
to be
right.
correlated with a solid phase assay.
And you need more than these 4 samples to say that this helps differentiate.
Yeah, I mean-
benign.
Definitely, yes. All right. Well, another, you know, point I wanted to touch base when I was reading is, you know, using that as a prognostic or predictive biomarker, so not as a diagnostic only biomarker. It's just a, you know, nice picture I wanted to share is like looking at biomarkers, whether you can look at biomarkers as a diagnostic biomarker, which we just talked about, and then looking at, you know, with time, how this donor-derived cell-free DNA can give you prognostication of, you know, the allograft function. And this is where this study that was done, the Admiral study, this is a big cohort. They looked at, you know, 1,094 patients in 7 transplant centers. I checked University of Florida was not one of them. They looked at single kidney adult recipients. 90% were disease donor kidney transplant, and they excluded multi-organ or pregnancy. And they, you know, followed them for 3 years post-transplant with, you know, cell-free DNA surveillance. Every patient almost got a median of 6 results per patient. And, you know, the biopsies that they did were standard of care protocols. And they analyzed 3 things: the de novo DSA, the GFR trajectory of the allograft, and any signs of allograft rejection. And what they have found is they used a cutoff of 0.5%. And they have found over the 3 years that any persistently elevated donor-derived, which is, they defined it as one result that is more than 0.5%, did predict more than 25% decline in GFR over the 3 years. When they looked at the temporal relation, they saw that any value of donor-derived more than 0.5 was associated with 3-fold increase in development of de novo DSAs and significant elevations on donor-derived during rejection ahead of changes in serum creatinine. So they noticed that there is, you know, earlier increase in donor-derived cell-free DNA compared to the creatinine that lags behind. So their conclusion was this can be used, and it demonstrates a broader utility of cell-free DNA, not only as a diagnostic biomarker, but also in, you know, prognostication of patients. Then, other just brief, 1 or 2 slides about each, talking about the uses that they have, tried to see in borderline rejection in BK virus-associated nephropathy and in repeat transplantation. Regarding borderline rejection, the thing is, why this is, apologies, but yes, this is the slide that I wanted to share. Treatment of borderline, mild TCMR is controversial. I mean, there is variable practice among different centers, and the studies show modest or no elevation in many borderline cases in the donor-derived cell-free DNA. Now, I don't have a lot of studies to present to you, but this is, the summary of what I was able to read, that suggesting minimal active damage when they have only a modest or even no elevation. And when they looked at, donor-derived cell-free DNA, they said that it may identify which borderline cases that we need to treat and which are more likely to progress to higher grades, and we need to treat them by having, higher donor-derived cell-free DNA. And then, another, treatment guidance, they claim that it can be used in borderline rejection. It might be, justifying treatment, while when you have a donor-derived cell-free DNA that is normal and you have a borderline rejection, you might justify not treating them and just observing. In BK virus nephropathy, the problem with BK viremia and that it develops in approximately 15%, and 1 to 10% they do develop BK virus-associated nephropathy. And this can actually mimic rejection both clinically and histologically. And both have, 2 different approaches. One is increased immunosuppression, one is decreased immunosuppression, and both of them can coexist at the same time. So, for example, like this study, they looked at, how donor-derived cell-free DNA can predict BK virus-associated nephropathy. And their results is basically that if you look here, BK viremia alone, without causing BK associated nephropathy, they had low AlloSure, but significantly more elevated, around 3% of AlloSure in BK viremia that caused nephropathy. And then as well, they looked at the BK viral copies and the donor-derived cell-free DNA Assure percentage, and it has somehow a linear relationship where donor-derived cell-free DNA would increase with the increase of BK PCR viral copies. And they were saying basically that higher donor-derived cell-free DNA were associated in this study with higher BK viral loads, with more biopsy diagnosed BK virus-associated nephropathy, as well as histologic criteria meeting the Banff criteria for T-cell mediated rejection. But I mean, the concern, like the most, they talked more about the BK virus nephropathy more than anything else. And it was statistically significant, the difference between BK viremia only or BK viremia with associated nephropathy. 0.58 to 3.38. And then another question that came up is, can we use it in repeat transplantation? The concern was, multiple donors might complicate interpretation of donor-derived cell-free DNA. But, with the evolution of technology, and as well, if we go back to what I said, is basically that donor-derived cell-free DNA has a short half-life, so it shouldn't stay in the system. So technically or theoretically, you can use it in repeat transplant. But there is really limited studies in repeat transplantation, how to, they have used and, numbers of donor-derived cell-free DNA. So reaching the end, I think, limitations and future directions, I think, to allow questions. The main thing I want to say is that there are still clinical limitations. It looks like donor-derived cell-free DNA has, lower sensitivity for TCMR detection, and it has, limited studies and data for mixed rejection when you have both ABMR as well as TCMR. And then there are variable cutoffs between studies. Some are using 1%, some 0.5. and there is no data on multi-organ transplant from the same or different organs. You can imagine, I mean, someone has a heart and kidney, and then, you know, you have cell-free DNA. Is it coming from the heart or is it coming from the kidneys? We do not have studies to, you know, study this. So that's, you know, one thing. And the other thing is the cost considerations, which is, you know, limited reimbursement and the cost effectiveness. Those all, you know, remain limitations. So I think, you know, future directions going from here is that we need more prospective randomized trials to investigate the role of DNA in improving outcomes, as well as, you know, right this moment, there is insufficient data to use it for continuous long-term surveillance. And then, you know, with the other emerging non-invasive biomarkers, maybe we can use all of it to complete the puzzle and, you know, try to limit, or as you said, like the kidney biopsy will still remain the, you know, gold standard for now, but at least help rule out rejections without the biopsy. And then, you know, the economic implications of this also needs to be investigated. So, I mean, this is the summary of my talk. I think we touched base about the biology of cell-free DNA, the different applications, how the measurement techniques advanced, use of donor-derived cell-free DNA in rejection, correlation with DSA, prognostication, and some other uses that are in the literature. Thank you.
So I think another thing too is in combined organ transplant, it's still not well started. Another is reimbursement. Medicare patients are good, but if they're commercial insurance, it's case by case. Like Blue Cross, they consider it experimental, so they would not pay. So
How expensive is it?
It's not too expensive for you, but
It's like a case that just.
Yes, please.
Thank you very much. Thanks for the review for us. Nice to have it out there. Do you think there's any utility for this test to delay graft function?
Well, I think theoretically speaking, maybe less, because as you said in the, you know, as I mentioned in the chart, you can see that there are already elevated levels to begin with. So, you know, in the first week, and, you know, to stabilize, it needs at least 10 days, and, you know, maybe more even to stabilize. So delayed graft function is, you know, more than, you know, it's in the early period where you can still rely on donor-derived cell-free DNA to detect, you know, the delay.
So we're just seeing this cell rate.
Yeah, so I think biopsy would be more, you know, reasonable in those cases.
it may have a role, not on the early BGM, but we have patients with cell phone still needing dialysis for 2 to 3 months post-transplant. Those are beyond the message they're showing. Because in the very old guideline, 2009, they say, if they're in DGF, you have to biopsy them every 10 to 14 days. So if so at least on the later time of DGF, you can avoid some of the diabetes because it's a good rule out.
But I think the problem with this is basically patients who are on dialysis. I mean, you can see that there is transrenal, you know, clearance of donor-derived cell-free DNA. So the question is, does dialysis will clear the?
No, but you know, that's why you have,
Like creatinine.
no, but you have, so you,
In between,
you say you do this pre-dialysis, then,
Yes, like-
then you have a baseline and every pre-dialysis day you do that. I mean, you just have to be consistent when you do it. And then you compare the baseline. And then you do that. That's why we do creatinine. How do you know they're predicting they're getting better? Before dialysis, we check that in the dialysis unit, every pre-dialysis, like on Monday, we check if the creatinine gets better. Something
Just,
like that.
you know, I just think creatinine is much cheaper. That's why.
These are two different factors. The creatinine is to predict that the BGF is getting better. This is to predict that there's a rejection.
But like, do you think they will reimburse like having those like multiple?
If they are on Medicare,
If they are Medicare, okay.
there's no.
No, I'm not
yeah.
claiming that I creatinine anymore. No.
No, the creatinine is to prepare that your kidney is recovering.
Yeah, yeah.
This is to make sure that you are ruling out rejection. These are two different things.
You say that because you're not sponsored, Tom.
Otherwise, I'm just a fellow. All right, thank you.